Welcome back to the Change Position. I am Melissa Cady with my co-host, Dr. Kevin Cuccaro, and we are here with the Change Position discussing all these wonderful topics leading into our almost 100th episode coming up very shortly for our transition to a new phase, an exciting phase for the Change Position podcast. But we had a little discussion today discussing actually my own practice just as an anesthesiologist, and it really brought up this idea of the value-driven practice. And so I guess I'll go into it, Kevin, and give an idea of kind of where this all stemmed from, because I think it has made it much more enjoyable for me as a physician. And much of what I do now as an anesthesiologist is I have two different positions that I cover. I've been very fortunate to be able to just work directly with them, not with a group, and kind of call the shots. And when I started working, actually right after the pandemic, it was initiated June 1st, I started doing a practice that was totally different than what I had done before, which of course I did locums after leaving a group after 9 years. But this particular practice, I wanted to be able to meet the patient beforehand. I always felt like it was very stressful for physicians that are providing anesthesia, or even for nurse anesthetists, anyone that's trying to just quickly meet the patient, look over their chart, create a plan, build a rapport within 5 minutes, and then try to describe and keep them informed about what to expect. And if we're really honest with ourselves, I don't feel like a lot of patients are well informed about really what to expect with anesthesia. Now, granted, they're not going to be able to know everything, but I think there's so much tension, anxiety, and feel free to chime in, Kevin. I know I just kind of took the floor, but I feel like, there's just so much anxiety that's in these settings that it'd be better to talk ahead of time. And I was a little bit, I wouldn't say envious, but I was a little bit jealous of that, a little bit of rapport and relationship that the patient had with the surgeon, and more because they already kind of knew them and they're like their physician, even though some people get confused that anesthesiologists or people providing anesthesia can be physicians. I decided in order to do these most predominantly cash-based type of cases, I wanted to go ahead and do the preoperative assessment ahead of time. So I arranged for the surgeon to send me information. I have their phone number. I text them. We set up a Zoom meeting like this and have a conversation about their medical history. I give them a basic play-by-play, what to expect the day of, so there's no surprises. I think half the battle is, kind of knowing what to expect. It's all about expectations. And then I make sure I answer all their questions. And then, of course, at the end, then I can tell them I will invoice them and they can pay ahead of time. So from a business model, it just made a lot of sense. And I've kind of tweaked it over time. But this has been the most profound difference for me, even for my days of anesthesia. So I don't have to be stressed out in between cases. Even though we don't think we're stressed out, it is a little bit of tension to try to transition because everyone's waiting on you. And as fast as you may go, it's like never fast enough. And so for me, I can take a little 3 to 5 minute break after I drop off my patient in a recovery room before the next one. My nurse can go sedate the patient, bring him to the room. It builds in my own breaks when I don't have other people other staff to help me out. So my personal feeling is that the benefits, and I've done a lot of feedback forms for my patients and gotten a lot of feedback. And even right after my preoperative interviews, that they're just so grateful they can talk to me beforehand and that they feel just so much better and relaxed about it. Even if they are a little bit nervous the day of, they just feel at ease and feel like they trust the people taking care of them because they've taken the time out to make this important so that we listen and hear them out and not be distracted. So for the patients, there's a lot of feedback that this was alleviating their anxiety, helping them understand things better. Other family members have the opportunity through Zoom to discuss these things and they understand it too. Coordinate schedules a little easier. For me, it just makes my day with the anesthesia with them better, and I can be better prepared if there's something we need to do ahead of time. So the value, I feel like, is not necessarily a monetary thing, but a very much driven by the experience. And what people really need is to be informed, well taken care of, and all their questions answered, and they're on the same page. Thoughts?
So, yeah, well, there's a ton there, right?
Yeah.
And what you're sort of defining is the value-driven anesthesia practice. And one other thing that you've done that you sort of cracked the code on, which for a specialty such as anesthesia, like let's take a couple step backs. Like we've had interviews with a lot of people who do direct primary care. And one of the most powerful things that you can do, I think, as a physician is remove the middlemen, right? To take control of your practice as well as to deliver medical care in a way that is focusing on who ultimately should be benefiting from that, who is your customer, client, patient, whatever we want to call them. The only way that you can do that in such a way without a bunch of outside interference, or where the value exchange gets warped in a lot of ways, is between a direct cash kind of flow. And I never saw how an anesthesia could ever do that, because it is a very specific specialty. It is, typically we have two sort of people that we're trying to serve at the same time. You have the surgeon as well as the patient client. And then if you're in a typical setting, then you have another person, which would be the insurance company. And then the fourth one, maybe the hospital system and all this other stuff. So it can be very, very hard for anesthesia. And so what you have done with this setting, and we should probably talk about a little bit more, is that, creating this cash-based model, and you can only do that with certain types of surgical practices that have a cash type setup. So that there's a limitation there. But the advantage is what you've done is then you've crafted a practice that you now can serve both of those clients in a very value-driven way. So you have an established relationship with the surgeons who know now that they're not getting a different anesthesiologist every day. It's someone who they work with that they can expect that they know your habits. The advantage you have is you're working with the same surgeons over and over again. So you know their habits and what their likes are. And then finally, for those cash-based practices, or practices where they are focusing on the client, the third person and the most important member of this kind of triad thing is the client themselves, the patient client. Because now, from a surgical standpoint, they're interacting. They have these pre-op visits that are built in, and everybody knows because they're built into the feed structure. But the frustration I could see from the surgical side is when you don't know who the anesthesiologist is going to be in that type of interaction, what they're going to say, or what the expectations around it. So now you have a point where you've got somebody who the anesthesiologist who can talk to the client, provide great patient interaction, explain the anesthetic on that side without a time pressure. So, and then increase and pave over those preoperative expectations from the anesthetic side, which again, that enhances the patient experience. Yep. So, I'm just sort of amazed at that, because for so many physicians who are looking for ways to sort of escape the system, oftentimes the first thing we say, well, that won't work for me. I can't do direct primary because I'm an internist and I want to see kids. Well, you don't have to have kids if you can actually do an adult only practice. Well, I'm a hospitalist. Well, you can take hospitalist medicine and actually transfer it to maybe outpatient critical care, where you actually have sick people that you are optimizingly managing through a cash-based practice. And you can even tailor your service to that, where you would actually say, hey, I'm a complex care physician for direct primary care for complex patients. But for the surgical subspecialties, and when we're going to put anesthesia in there, of course, we're in the sort of the nomad land, it typically hasn't been seen. And so I love that value-driven idea. And the other part about that, which I think is important for the listeners to understand, is what we're defining as value. So in this, you obviously are getting paid. You are obviously being able to maintain a standard of living. Maybe you could make a heck of a lot more in a big anesthesia group, but you'd also have a lot more stress. You have a lot less time off. You'd have call requirements I don't think you're not doing overnight call or anything like that. No. But value is beyond money itself, right? And I think that's the thing that people get really, really hung up on, is when we're talking about value-driven practice, we are not just talking about monetary income. Right. We're talking about the fact that you are serving and providing what your client needs. That's where that value exchange truly comes in. And what has been warped and twisted in healthcare for so long is that somehow, like, we're supposed to provide value, and in return for that, we're getting value from the client, which is usually some sort of monetary thing. Healthcare doesn't do that, because the money flows to different. So, you have insurance, you pay your insurance, it goes off to the insurance provider or, whoever it is that you're paying for your insurance coverage on. Then the insurer now is going to pay whoever the service provider is. And the service provider is then delivering those services to the person, to the client or patient. So because of that sort of triangular flow, there is no direct exchange of value anymore. Unless they're all lined up, you're not going to have this perfect exchange. And it's not ever going to get lined up, because if you pay money to an insurer, then the expectation for the patient or the person paying that money is, I want the best services that I can get. The insurer, because they're getting that money, is going to say, I want to retain as much of this as I can get. Mm-hmm. And then you have the clinician involved, and the clinician is saying, well, I want to get reimbursed for my services as best as I can. And all of those are in conflict. Mm-hmm. And yeah, it's just remarkable to me that the entire healthcare industry is in such a way where we are not aligned to actually, and I'm going to use capitalistic manner, in a way to deliver services in a way where that value exchange is actually appreciated. And there's this inherent conflict in everything that we do. So I just applaud the fact that you've found a model in which now that value exchange is actually aligned, is like totally aligned. Yeah. So those are my thoughts on that.
Well, thank you. And, you made me think of, a few things. And so 10 to 15% of my income is insurance. It's predominantly cash-based, but my model of what I value and what my patients value is still provided despite the monetary exchange or how things are paid for. So even those that are under insurance, or hoping insurance pays, I still provide this. And, if they cancel their case, they don't have it. I mean, I just provided free education. That's my contribution to society as far as how I see it. I don't necessarily bill for that to the insurance. I just bill for the surgical, anesthesia, which that's probably something I could look up. But personally, I'm just crossing my fingers, like you said. I'm crossing my fingers that, they'll pay me. I still have 5 outstanding claims from 2020 that I'm still waiting to get paid on. So I may not, I may not get paid for some of that. And the sad thing is that when I turn around and I tell patients that I love, let me just put it this way. I love having them pay ahead of time before the anesthesia for a lot of reasons, because when I suddenly get the insurance explanation of benefits that says, they're going to have to pay $700 and you have to reach out to the patient and ask for that money later, there's more conflict that can happen because of their expectation of all the money they put into that insurance for their deductible or their monthly rates and whatnot. And then suddenly you're asking them to take out more money when they thought the value of the insurance they got is going to pay for these things. So like you said, we're all in conflict, but it just feels worse when you feel like you created such value. They got through something, flying colors, they did well. You did the best you can to care for them, to educate them and all of these things. And what's thrown in your face? Insurance won't pay, patients frustrated. It's just there's no harmony there in exchange for the value that I feel like I provided. And so it's an unfortunate situation to be in. And that's why I only do this as a service to the surgeon because, they're taking the insurance. But other than that, I don't really enjoy the whole insurance thing.
Well, well, yeah, because they're setting that up in such a way that there is a conflict, right? Mm-hmm. What ultimately really should be happening is that the insurer should pay you, mm-hmm. and then they should be, because they're the one who is ultimately supposed to be the middle person between the client and whoever the service provider is, and they don't do that, right? That's why they always, well, you're the responsible for this and blah, 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 but. Yeah,
it's really weird because I have to go to the patient to pay and yet they deduct it from their deductible that's required. Now they get credit. And this is my understanding. They get credit, say they owe $1,000
Mhm.
And it's documented that was an allowable amount. The patient's responsible for it. That $1,000 is put towards the deductible. Well, what if the patient never pays me?
Yeah.
They just got credit towards their deductible. I don't get paid. And yet I agree with you. I feel like the patient, it's almost like if you're going to make this third party kind of run this thing, I almost feel like they should pay the insurance and the insurance pays us. So the insurance can go after them if they didn't pay what's actually applied to the deductible.
Yeah.
I don't,
To determine everything else. No, I totally agree on that. And because again, that's that value exchange model. And there's also a psychology there, where it has to do with the whole idea of paying for a service after it is provided.
Yes.
So there's an example. There was a restaurant, and I can't remember the exact name of the restaurant, but one of the things they tried to do is like, hey, you can come in, you can eat, and then you pay what you think this is worth at the end. Well, they went out of business. Sounds really, really great. Oh, egalitarian. This is going to work so well. But it doesn't fit with human psychology. In this human psychology, there is a very big difference between something that you don't have and something that you've already have. Yes. You tend to, if you already have it, then you tend to think, well, this is mine, and you're going to retain it, right? If it's something that you don't have, then you're more willing to say, well, I actually will pay X amount of dollars for that in advance. Yeah, I'm sort of butchering the psychology around here a little bit because it doesn't quite fit the example that I'm thinking of. But what the way they discovered this was like literally like they had like stupid gifts, and they said, okay, here's a coffee cup. How much would you pay for this coffee cup? Yeah. And they were like, oh, we'll pay. This is a dumb coffee cup. I'll pay $2 for that coffee cup. Yeah. So all right, well the value of the coffee cup is $2. Well, then they gave people a coffee cup and said, hey, you know what? We actually want those coffee cups back. How much should we pay you for that coffee cup? And they said like $3 or $4 or $5 for the same stupid cup. But the only difference is there's this specific quality to it. So when you were put up in this situation where now you've already delivered the service, they're like, hey, this service is already mine. What do you mean I have to pay you anything else? So even on they're already in possession of the thing, and now you're asking them to pay for it. They're not going to, they're not going to want to pay you because they already have the result that they wanted. And so as of that, it's your value is no longer seen as contributing to that anymore. Right. Well, sounds awful, but it's just think about it. I mean, we can almost think of all our own personal examples of when someone comes back and says, hey, you actually owe this. How do you like that? Nobody likes that. Yeah. Wow.
Yeah. I feel like when, especially in my field, it's like life or death feeling like you're taking care of me. I want you, I want you to know I appreciate you, that, I trust you, and please take good care of me. And that money is like they're attaining something good. And the moment it's afterwards, it's like you're taking away from me. That's how I feel like the psychology is.
Well, and you also have the time perspectives involved in it as well. That's a past event. That doesn't even matter anymore. Yeah. And I don't historically. Yeah.
Yeah. And like, even like getting paid for something, like sometimes I don't want to be paid too soon for it. Like I want the proximity of the payment and what I do for you to be within a few weeks, like couple weeks, like even from cash flow. But truly, honestly, we're talking about this value-driven practice. And to me, I think a lot of people in medicine that have been burned out don't feel that fulfillment that they really want. There's that disconnect from the monetary issue is really conflicted with that experience of the time with patients and that alignment of values. And I feel like, having a practice that's not too big, that keeps us still connected with people, and where I take a lot of pride in delivering care that's appreciated, and that I'm connected with how that experience is, that to me is valuable. And the patients, I really feel it. Like I feel like there's a genuine, some people you're just not, they don't know what they're missing and they don't know the differences, but those that have been through the operating room, and to create this different kind of experience for people and try to have some organization to it and a flow and keep it professional, like that's something that actually brings me a lot of joy. And there's inherently stress in this kind of job anyway, but most of my patients are relatively healthy. So I don't have the same kind of stresses like in the hospital settings and some really sick patients. But, it's just something that it's an opportunity to give a little dose of education that they're willing and ready and willing to accept. And for you and I who like to teach and like to educate, it's a great opportunity to get that little bit in there and then provide service directly to them, and then follow up and be honest with yourself on like what that experience was like for them. That to me is I don't know, part of what we do in the general anesthesia world is care for people. And I want that to exude. I want them to know that I genuinely care. And so to feel like that's, actually happening, I didn't have that kind of control in a group setting.
Well, and those are the intangibles, the intangible value, right? So tangible being the monetary portion of it, but there's the intangible. And that's like, if you're a new physician going into a position, those intangibles, or actually wherever you are in the spectrum, the intangibles are as important as the tangibles are.
Mm-hmm.
People focus so much on this is what I'm going to get paid, blah, 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 blah. Well, what is your life going to be like? Who are the people that you're around?
Mm-hmm.
What are the cases that you're going to do? What are the expectations of practice? And those intangibles, you may find out that the job that pays you is at the high end of the spectrum. There's a reason it's at the high end of the spectrum is because they burn people out really quick, and or the people that they attract to that are not the most pleasant people to deal with. And so people who perhaps can't adhere to that or don't enjoy that, where the value, where they're not a value driven, they're a monetarily driven clinic or whatever, tend to leave. So yeah, those intangibles, that's a whole nother discussion right there, is how the intangibles have gotten ignored in the healthcare system. It just astounds me.
Part two.
Yeah, we could talk about that part two, is just how healthcare systems don't invest in the intangibles or don't value the intangibles in such a way that they retain their own physicians. And instead they're willing to, say it's my way or the highway, or we're not willing to negotiate, or these are just the expectations. We're going to change them arbitrarily, even though we have absolutely no idea what the repercussions are. We can always get a new physician. Oh, by the way, it's $250,000 on average to recruit a new primary care doc. It is significantly greater than that to support a specialist. And when you have an environment where maybe 1, 2, 3, or 4 or longer years before you can even attract another clinician, they don't even think about the loss of value there. Monetary value to the system. So that we'll save that for another discussion at some point.
Well, maybe we should create a second, be our episode 99.
Episode 99 on intangibles in medicine.
Yeah, well, we can discuss that. And I just this whole thing about the value-driven practice, I think you have to be honest with yourself of what it is that gives you joy in the field, and try to apply that or create. I was fortunate that I had these relationships prior that I really couldn't pursue, but fortunately, what I delivered on my end, despite being in a group, they pursued me and asked me to deliver their anesthesia, not knowing the new system that I was going to implement. And fortunately, even the surgeons recognize the value. When the surgeons hear back from the patients of how grateful they are to be able to talk to them beforehand, the anesthesiologist, or even the follow-up, and just any of the things that I've been doing that's different, it makes it a better experience for the patients, for word of mouth, for the surgeons, for future cases. So now that this whole value system has been recognized, it kind of helps me from a business standpoint to kind of, there's no guarantee, but it helps solidify my presence and being able to continue this kind of business relationship for patients in the future. Were you going to say something?
No, I was thinking about a couple different things. Is from a nuts and bolts aspect, what this is, the difficulty for someone trying to start your model would be that you had an established relationship with those physicians, so they could see what you did. So, so they could see the value that you were already previously delivering, in which case that they appreciated that. That would be, if you're just trying to start this out of the blue, that could be hard to do.
Unless you trained with some people in residency and that relationship can be in the same location.
Well, and then
Yeah.
your value, then you'd be leveraging your network, which is a whole nother, of the 5 types of capital that we talked way back when with the fabulous Dr. Tate.
That's right.
But then this also, and what I'd like to do actually is let's wrap this up, because what this also reminded me of is the fact, if you have a value-driven practice, you have to know what your values are in order to do that. And that's going to change the game on what you perceive, what you pursue, ultimately how happy you are in your practice. So if you're up for that, I'd like to do an episode on the values behind a value-driven practice.
Perfect. Well, then take us out on this episode.
All right. Well, folks, thank you very much for joining us for another episode of the Change Physician Podcast. If you're interested in joining the community, be a little bit more informed when we do send out some little notices here and there of what's coming up and what new things we're anticipating. Go to thechangephysician.com, sign up there. Or you can join us live on Fridays. We're on Facebook at The Change Physician. We do the Friday faves every Friday evening, varying times, but usually around between about 4 and about 2 and 5, I'll say, Pacific Standard Time. I don't know what other weird time zones are out there. You have to figure that out yourself. But until next time, stay well.
Take care, everyone.